they give the countdown.
Hi, welcome to Iron Health Talk with Dr. Akram. I am Akram. In this program, we'll be talking about all kind of different health issues with different experts in the field. But today, we're going to talk about rheumatoid arthritis, and in the end of the program, we'll talk a little bit about gout arthritis. This is really important. Let's see. Arthritis is a common condition that causes pain and inflammation in a joint. In the UK, more than 10 million people have arthritis or other similar conditions that affects the joints. Arthritis affects people of all ages, including children. Osteoarthritis and rheumatoid arthritis are the two most common types of arthritis. Osteoarthritis is the most common type of arthritis in the UK, affecting nearly 9 million people. It most often develops in people in their mid-40s or older. In the UK, rheumatoid arthritis affects more than 400,000 people. It often starts when a person is between 40 and 50 years old. Women are 3 times more likely to be affected than men. But gout is a form of inflammatory arthritis characterized by recurrent attacks of red, tender, hot, and swollen joints. Pain typically comes on rapidly reaching maximal intensity in less than 12 hours. Let's look at the evidence. Evidence of osteoarthritis and potentially inflammatory arthritis has been discovered in dinosaurs. The first known traces of human arthritis date back as far as 4500 before Christ. In early reports, arthritis was frequently referred to as the most common ailment of prehistoric people. So arthritis is really important for us. So for that reason, we brought a specialist in the field, Dr. Roshan Amarasena, who is a consultant rheumatologist who is working in NHS in the Midlands. Roshan, thank you very much for being in our show.
Good evening.
You had a long drive today. Thank you very much for specially coming for our Iron viewers to the studio and share your experience.
It's my pleasure to be here.
Right. Before we go into the program, why did you choose rheumatology as a specialty?
If I were to start, I trained as a general physician, and rheumatology is a specialty that encompasses a lot of subspecialties. And rheumatology is one specialty that you deal with the patient and you have a journey with the patient. And I felt that compartment of that element of rheumatoid arthritis gives me more of a connection, and I feel that I can treat and understand the patients better. So there's a long sort of relationship that we build and trust between the patient and the consultant. And that is very fulfilling to see that your patient's journey with yourself, and it is a partnership.
That's very interesting. Rheumatology is not that bad as it used to be like 20, 30 years ago. Now there are lots of medications there in the field, and we even know a little bit more about it, but we're going to talk more in detail. But anyway, this is a live program. If you have any questions, you can always call us on 0203 515 5788. Or you can always write to us on our YouTube channel, Health Talk with Dr. Akram, or Facebook, Twitter, or Instagram pages. We'll come back to you in the future with that. But let's go back to the program, Roshan. Okay. What is rheumatoid arthritis?
So, as you have given in the introduction, I would like to first start. Most of the people mistake when you say rheumatoid arthritis as osteoarthritis.
Exactly, yeah, there are two forms, isn't it? Let's explain both of them so they will have an idea.
Yes, so osteoarthritis is plain and simple wear and repair or wear and tear.
The wear and tear.
Yeah, so with age, for whatever strains you have taken, whatever sport injuries you have incurred, whatever occupations you are having with repetitive strain, over time you will get some degree of degeneration, and that is normal. That is the process of aging, and that is just a gradual process. But rheumatoid arthritis is totally different from osteoarthritis. It is an immune or inflammatory condition driven by the immune system. We can discuss that in a little bit more detail. So we should really understand that these two are two different things. Most people, when you say arthritis, they prefix themselves with osteoarthritis. Right?
Exactly, yeah. You know, when for a common man, when they say arthritis is one entity for them, but in medical term we have a different form because
That's
it
right.
affects in a different way as well, isn't it?
The mechanism, the disease process, everything is totally
Yeah.
different, and the management is totally different. So, yeah, so it's important that one understands rheumatoid arthritis as a special, different entity. Of course, the commonest arthritis is osteoarthritis because we all age. Because we all age, with time, for my age, I have some degree of osteoarthritis. For your age, you would have.
Exactly.
And with time, it will get worse. And of course, it's going to be $1 million question if we can slow the process of aging and prevent osteoarthritis, but that's a different topic.
That'll be a good topic actually.
Yes, it will, definitely, yes.
And if you find a medicine, you can of course win a Nobel Prize for that.
I know, definitely, and a lot of people actually working around the world
yeah.
to see whether we can slow the process of aging, with so many new concepts.
It's actually, there are 5 communities in the world they call the blue zones, and these people tend to live to 100 and above 100 happily without any problems. There are possibilities.
Yes, and we don't know whether it is the diet, whether it is the genetics, whether it is so it's unknown.
They are still
unknown
under
at the moment,
studies.
yes.
Yeah, that's right. And okay, rheumatoid arthritis, how does it affect? How does it evolve in your body?
So, as you in your introduction also mentioned, rheumatoid arthritis can occur in the middle age, after age of 40, but you can find it in the younger group as well. It is where your immune system has got ignited. Now, I always tell my patients, we all need an immune system, and the immune system is one that is there to react to infections, to react to diseases, so that it can fight the disease.
So it works all the time. It's the immune system, especially in your nose, while you're breathing and breathing so many different kinds of bacteria and viruses. The immune system is there. They attack and unnecessary things, they get rid of them.
That's right, and that concept is very important because when we understand the management process, because the immune system is a dynamic process and we need to keep it at a certain level.
Right.
Too much of it is bad. Too little is bad.
It's bad.
If it is too little, you're prone to infections. If it is too much, again, you can get cancers and things like that. So we have an immune system that is a certain level. Within that certain level, it is thought to have a good function and a balance. But for whatever reasons, which is totally not very clear, our immune system gets ignited.
Right.
Right? And it might be a virus, it might be stress, and we expect that to come down to the normal balance. But in occasions, it doesn't come down. It remains in overdrive. When it remains in overdrive, it is working more than it should. And then it mistakes certain elements in your body and starts attacking them.
So the immune system thinks a certain part of your body as a foreign body.
As a foreign body, or mistakes it to identify as it is your own.
Okay.
And therefore, it starts attacking it. And in rheumatoid arthritis, that target is the lining of the joint, which we call the synovial membrane, or the thin lining that coats the joint. And so what happens is, as I told you before, the immune system is on overdrive. It's attacking the joint. So with time, when this process propagates, it's a vicious cycle. And it pours out a lot of chemicals into the joint, and with time, it erodes into the lining and then to the bone underneath the lining, and it eats into the bone. So you made a good point at the start, saying that at this stage, we don't see much of the deformities. Yes. Now, when I see these patients in the clinic, and when I tell them they have rheumatoid arthritis, they get a flashback of their grandmother in the wheelchair.
Yeah.
Right?
Yeah.
They get a flashback with the grandmother in the wheelchair, and and actually the consultation comes to a halt because they can't perceive anything more. But nowadays, that is, if you see patients developing that degree of deformities, that means you're not treated them well. We treat them
well,
like treating cancers. We treat them aggressively so that we hit them hard with all our immune therapies, so that we prevent the progression. We can discuss that later.
Yeah, the drugs are very good in these days. Because I remember when I was a medical student, we used to go to our rheumatology appointment, and always saw deformed, joints and all these things. But as you said, we rarely see them now. So
Yes.
that's a really good news for
And
us.
I think that's the message that we should send to the public is we like to see the patients at the slightest inflammation. Okay,
Yeah.
We don't want them to progress at home and come to the GP or come to us at a later stage, because then the improvement that we can gain is little and the permanent damage that is there.
So what kind of hint would you like to give our public about happening arthritis is
Okay.
brewing there?
So first and foremost, any joint pain, I mean joint pains are common, right?
It's common, of
Joint
course,
pains
yeah.
are common. I tell my patients if they get swelling
Swelling.
in a joint, that is a very strong physical sign.
Yes.
Okay, a swelling that persists in a joint for more than 3 days has to be looked at. Okay?
So if a swelling in a joint lasts more than 3 days,
Just be concerned of it and
Concerned.
then ask attention for the GP. And with rheumatoid arthritis,
go to the GP. Yeah, of
yeah,
course,
yeah. With rheumatoid arthritis, it is reasonably easy. It could be triggered off by stress. It could be triggered off by a virus. It could come out of the blues. Okay.
Yes.
And because rheumatoid arthritis has a particular pattern, it's symmetrical. So if you have it in one hand, you might have it in the other hand.
Right.
If you have it in the right knee, you can have it in the left knee.
So can it affect all joints?
It can affect all joints, but
Generally, what are the joints it like to affect?
so we classically say the joints that are affected are the big knuckles here,
Big knuckles.
yeah, and the line next to that.
Oh, right.
But it spares the end joints in rheumatoid arthritis.
Generally.
Okay. That is more common in osteoarthritis.
Osteoarthritis.
And it can affect the wrists, it can affect
Wrists.
the elbows, it can affect the knees.
Knees.
Yeah.
So these are the joints they get affected. So suddenly you started feeling a swelling, pain.
Yeah.
Last 3 days, think that you're going to go to the GP and show them.
And I think one thing more, stiffness.
Yeah.
And the key thing here is pain is worse at rest.
Okay.
So that is the difference between rheumatoid arthritis and osteoarthritis. Osteoarthritis pain is worse after work, after strain. In rheumatoid arthritis, the pain is worse at rest. So people tell me, I have driven, I can't get out of the chair, I'm stiff, my joints are swollen. First thing in the morning, the joints are tight.
So it's in the morning, right?
It's in the morning and after rest.
After rest, you've been sleeping all night and you wake up, your joints doesn't want to work
Yeah.
suddenly.
And so that are the first signs of stiffness when at rest, swelling, pain, better with exercise.
Right. Once you're moving around,
Yeah.
and that's why people ignore it, isn't it?
Yes.
Oh yeah, I have a bit of stiff joint. I wake up, have my tea or coffee in the bed, and I started walking
Yeah.
around in the house or going to the toilet, and the pain slowly goes down, and they ignore it.
Yes, and that's why I think. But if you let it go, it will persist. So if you have really inflammatory arthritis
Right.
or rheumatoid nature, it will persist if you don't treat. So
it's always good to disturb the GP for this condition
yes,
if anyone
definitely.
has it.
And actually, I will want to give you a hint here. We have in the UK a standard that any patient with suspected inflammation in the joint needs to be referred to a specialist within 3 working days.
3 working days.
So that is a very quick, fast.
Okay, Roshan, we're going to talk more about rheumatoid arthritis, and before that, this is time for a break. And if anyone joined the program, we are talking about rheumatoid arthritis in the first part of the show, and later we'll talk about the treatment, and we'll jump into talk about gout arthritis. So be with us. See you after a short break. Hi, welcome back to Iron Health Talk with Dr. Akram. Today we're talking about rheumatoid arthritis. So far we have discussed the basics of the rheumatoid arthritis, and we're going to talk more into rheumatoid arthritis. We're going to talk about the diagnosis, treatment, who gets it, and what you could do to prevent it, all these things. So in our studio we have a special guest, Roshan Amarasena, who is a consultant rheumatologist in NHS, and he works in the Midlands. Roshan, okay, let's talk about the risk factors. What kind of lifestyle, what the bad things we do, or the good things we do, does it produce this disease?
Yes, so rheumatoid arthritis, there are some genetic links, but it doesn't mean that your children or your relatives will get rheumatoid arthritis even though you have it. Of course, the genetic makeup will trigger off the disease or the cascade of inflammation if you have some triggers. As I mentioned before, the triggers are stress.
Okay. I'm going to hold you there, Roshan. There is a caller coming in. Join with us. Hello. Hello.
Hello.
Hi, please go ahead. Walaikum assalam.
আমি একটু ডাক্তারের সাথে কথা বলতে চাই।
Okay. Can you talk in English, or if not, the studio will take the call and they will translate it for me.
Oh, so I can tell English is okay.
Yeah, sure. Yeah, please go ahead.
What language you are?
Yeah, please talk in English. Yeah.
Only English, no Bengali.
No, our studio can speak Bengali and they can translate it for me.
Okay. I want to talk to doctor with my arthritis.
Arthritis, yeah?
Yes, it's my leg is pain, sometimes my back pain, and sometimes my knee pain. So, so I have already kidneys problem also. So I don't understand my arthritis pain or my kidney is painful, everything going to his body, or the arthritis. So my knee pain, so what can I do, what I eat, everything explained, doctor is can better.
Okay, thank you very much. This is a very interesting question for us, and especially you talking about our subject, what we're talking about, the arthritis. Thanks, and I will discuss the question so you can listen to us, and definitely we're going to give you more into the arthritis. We'll explain everything about it. Yeah, thank you very much. Okay, Roshan.
I hold it?
Yeah.
I hold, okay.
Yeah.
So did you hear the question?
Yes.
So this lady, I think she's suffering with arthritis, and she's got some kidney problems as well.
So it's interesting actually. Of course, it's difficult to make a complete diagnosis. It could be depending on the age and the type. I would like to ask a few more symptoms and questions to investigate that. But a knee pain could be because of osteoarthritis. If she is overweight, that can cause strain and mechanical pain. Likewise, if you have kidney problems, your kidney functions might be a little bit weak, and it can trigger off gout.
So
there is a couple of things. Of course, the common things are common, and with knee pain, it's most likely to be osteoarthritis. Now, of course, she mentioned about back pain. Back pain does not occur in rheumatoid arthritis, so we can clearly say that the back pain is not due to rheumatoid arthritis. It's most likely due to degenerative arthritis.
Okay, thank you very much. There's another caller coming in. Hello?
Yes, and doctor, something asked me, I think. So could you give me the line for the doctor, please?
Yeah, you're talking to the doctor now. Please go ahead with your question, please. Thank you.
Okay.
We are listening to you. You can go ahead with your question.
Okay, yes. And I have, my age is 61.
61 years, yeah?
61. And my kidney urine number is 39.
Okay.
And that's why, I don't know, is it uric acid or something, explain.
Do you want to ask any questions from this lady, Roshan?
So, can I ask you, we'll talk about the knee
so
first.
Could you tell me, the uric acid make me the painful my leg, or arthritis painful my knee, sometimes coming my back, my so is the feet. So this is problem I suffering for.
Okay. Yeah.
So
okay.
I think.
So what I eat, what do good for me? Is the green tea is good for me, or is the turmeric and everything? Explain to me, please.
So generally, of course, for knee pain, we would say the advice is to reduce the weight if you're overweight, to increase the strength of the muscles around the knee so that you protect the knee, and of course, we'll need to do a few more tests, to do some blood tests to see whether blood inflammation is raised, to see whether it's inflammation related, and then of course X-ray is very important
X-ray
to
is
see
very
whether there's any wastage, any cartilage degeneration, or whether there's narrowing of the joint.
Yeah. Shall we get the number from the lady
Yeah.
so we could talk
Yeah,
after the program? Yeah. Sister, can you leave your number with the studio? I will ask them to take your number and we'll call you back after the program at 9:30. Is that all right? Okay. Yeah, studio, can you please take the number for us? Thank you. Let's go through the risk factors.
Yeah, so as I told you, genetics is, you have some genes that are predispose a patient to rheumatoid arthritis, but the genetic factors, the risk factors for rheumatoid, particularly smoking.
Smoking, right?
Smoking, and that has so many bearings. It could increase the risk of rheumatoid arthritis. It reduces the efficacy of the drugs. Okay, and it affect the lungs.
So it reduces the efficacy of the drug
drug.
as well. Yeah, of course it
So
affects.
it is a double whammy, having
Right.
being a risk factor. And even if you stop smoking, it can take many years to reduce the risk factor to the normal population. So if I can advise the patients, the first thing is to stop smoking.
Stop smoking.
And that is the only well-known risk factor that we have.
Which we know.
Of course, others are stress and things like that, which we cannot get away generally. But smoking is definitely
something you could avoid. Okay. How do you diagnose it?
So diagnosis, of course, is pattern recognition. So we speak to the patient, take a history, then examine, look at the joints that are affected, and once we suspect it, we then try to do some blood tests. So the blood test, would we like to look at the inflammation in the blood with some blood tests, and then of course we have some other special tests to see whether the patient has immune markers for rheumatoid arthritis, and that could be, we call it the rheumatoid arthritis factor or anti-CCP antibody. These are proteins in the blood that are put out when there is rheumatoid arthritis. But I should make a note here that about 20 to 40% of patients may not have these markers but still have rheumatoid arthritis. Therefore, it is important they seek specialists to pick the rheumatoid arthritis. So,
Right.
so there are patients who might have symptoms but not have the markers.
Marker. Okay. There's another caller coming in. Hello.
Hello.
Yes, please go ahead.
Yeah. Sometime before I had a urine infection, and it was my low stomach pain. But doctor checking urine sample and said you got a urine infection. Now, when I got urine infection, both backside, low backside pain as well.
So you get low back pain as well. So
Back pain as well. Yeah, with urine infection, because Monday I got a urine infection, really
Right.
bad.
okay.
Yeah, I want to know, is the urine infection relative with the back pain?
Urine infection, of course, yeah, you can have back pain with urine infection. That is normal, isn't it? It's a referred pain.
Yeah,
It's,
yeah.
Basically, it's referred pain from the kidneys
Yeah.
or even ovaries. You can get the back pain.
But usually, of course, that's when the kidney infection becomes quite advanced,
Advanced,
by pyelonephritis and
Yeah.
things like that. So a simple urine infection should not cause back pain,
Back pain.
unless there is outflow obstruction and hydronephrosis.
Exactly, yeah. Okay.
So the kidney gonna be damaged if it's gonna keep on urine infection?
Okay. If you also, please, can you leave the number? We will come back and we'll talk to you. Definitely, we'll spend about enough time and explain you more in detail. We have a lot in program. We will run with the program. Then we'll definitely call you if you can leave your number with the studio. Yeah. Thank you.
Okay, thanks
Okay.
very much. My number always coming to the studio, or
Yeah. Please. The boys in the studio will take the number now. Okay. 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 We're talking about diagnosis. Yeah.
Yeah. So I've covered the blood tests, and
Yeah.
then of course we would like to do X-rays of the target joints, and usually we do the X-rays of the hands and the feet because that covers quite a bit of the joints. And of course we will also do a chest X-ray before we start treatment. And so we would like to first establish where the disease is, how much of the diseases affect the joints,
Yeah.
and then we start introducing the drugs. Of course, drugs comes in different forms. Pain relieving drugs, so you can take simple pain tablets, anti-inflammatory drugs like ibuprofen, naproxen, if it is suitable for you, that is to relieve the pain. But mind you, it doesn't change the course of the disease. So it is only a pain relieving drug, and it doesn't stop the process.
It doesn't stop the course.
So that is very important.
Yeah.
So some people, when they get the pain relieving drugs, they feel reassured that the symptoms are gone. So that is not. So we usually give it only to bridge the time before we give our specialized drugs. We have these drugs called disease modifying anti-rheumatoid.
So these are the new drugs.
No, these are the immune modulatory drugs. This has been there for ages.
Ages, yeah.
And these are tablets. Basically. So we call it disease modifying anti-rheumatic drugs, DMARDs. They could be methotrexate, sulfasalazine.
So methotrexate, okay, this has been there for a while.
Hydroxychloroquine and so forth. One thing important to note is when you start these drugs, it can take 12 weeks to kick in. Because it has to go into your system and modulate or change the immune system to calm it down. And that's why we give the normal pain tablets. And we may give short courses of steroids to buy time until these drugs take over. Of course, these drugs has its own side effects, so it has to be done in a very controlled way. We always have a shared partnership with the patient, with the GP, with your family doctor, so that the drug that is prescribed is monitored and looked after. Yeah.
Okay. Prognosis.
Yes.
What kind of what can they expect if they have a rheumatoid arthritis?
So if you're caught early, you should have a normal lifespan, and you should have a normal life, and that should be your expectation. And if you don't have that expectation, it is not what we want. We want you to have the normal expectation, do all the sports you want, and be as normal as you are.
So be as normal as you are, right?
We like to see the patients early so that we can give that normalcy to the patients, right? And as I told you before.
So you were telling that you had rheumatoid arthritis, not end of the world, that you're going to stop doing everything. They need to go back to be active.
Yes, they need to go back to work. They should not give in to the joints, and if there is pain, they should try to take pain relief and work, because the key concept here is to protect the joints with strengthening the muscles, but with the aid of immune disease, immune drugs that can calm the joint.
So the drugs will look after the joint, but you have to improve your muscles.
That's right.
So the muscles can hold is not much tension or weight on the joint, isn't it?
Yes.
That's the important thing.
And it's important that the concept of treating rheumatoid arthritis is a holistic management, and the patient is in the center of all this. So the patient has to take ownership of the disease, because however much I give the drugs that the patient doesn't engage in exercise, weight reduction.
So when you say a holistic approach, what are there?
Okay,
can you number them?
So the holistic approach is with the patient. It is patient-centered. So we have your rheumatologist, you have the specialist rheumatology nurse, you have the physiotherapist, the occupational therapist, the clinical pharmacist, the podiatrist, and clinical psychologist, all of them.
So as the patient, what do they expect? What do they need to do?
As a patient...
So you have given the drugs, they will take the drugs.
Yes.
And what else have they to do?
So first thing is for them to take the drugs, because some patients, when the symptoms go away, they think they don't need the drug.
Forget,
So I think it's important to understand these are drugs, long-term drugs. Of course, if your disease goes into remission or if it gets quiet, we can tend to reduce it, but these are long-term drugs. So it's important that the patients take the drugs continuously and be compliant with the drugs. And then, of course, as I told you before, we want them to go back to normalcy, go back to work, go back to normal exercise, so that they can have all the social functioning that they need as normal as it is.
As normal it is. Okay, we'll talk a bit more about rheumatoid arthritis after the break, and we're going to discuss more about the gout. Roshan, thank you very much. If anyone joined the program, we're talking about rheumatoid arthritis. We've got another 15 minutes left, and we'll try to give you as much as possible. So be with us, and we'll see you after a short break. Hi, welcome back to Iron Health Talk with Dr. Akram. Today we're talking about rheumatoid arthritis and we're going to talk more about gout arthritis. The program is we have left only 50 minutes. We need to talk a lot. But if you have any questions, please call the studio and leave your number. We'll definitely call you back in the end of the program and we'll answer all your questions. We'll take enough time and answer it. And Roshan, thank you very much for being with us again. Okay, let's quickly number the new drugs.
Okay, so we have this new class of drugs called biologic medications, and these are drugs that
Biologic medication.
biologic medication. Most of them are injections, so they are a step higher than the normal drugs that we mentioned before, the disease-modifying drugs.
Yeah.
And they have been developed in the last 20 years, but they have changed the spectrum of rheumatoid arthritis, and that's why we are not seeing the deformities. They are powerful drugs, and also very safe. We have data of 20 years now, and the signals are it's as safe or even much safer than the older drugs. But of course, because they are costly, we cannot jump onto these drugs as
So you don't give it as a
first line.
line.
We have to fail 2 standard drugs before we can subject a patient to this drug.
Most people, if you give the general drugs, it will help them.
Yes, I mean 60% would
60%
help. So
of
there is a 40% that don't respond or have inadequate response.
Right.
And therefore, then for these patients, if they have failed 2 drugs, the UK government.
Can you name some of them for us?
So we have drugs like etanercept, adalimumab. So I'm giving
Etanercept, yeah.
adalimumab, golimumab, certolizumab. I'm not giving the trade names. I'm giving the generic names.
Generic names.
And of course, these are injections that are given like insulin pen injections, so self-injectables. It's painless. Patients do it. And
Once a week?
once a week, once a fortnight, once a month, depending on the preparation. And generally, there is a little bit of screening test to be done, and they're quite safe.
So these are the drugs. Okay, what kind of resources our viewers can get about rheumatoid arthritis and all these things? Do you have literatures? Do you have magazines?
I think
information?
in UK, the rheumatoid arthritis, we have our own society, which is an Arthritis UK, which has all these
Could show it to the camera
now it's called Versus Arthritis. If you just Google it, you will find all leaflets for all the conditions. And of course, specifically for rheumatoid arthritis, we have the National Rheumatoid Arthritis Society booklet, which is very comprehensive and it's written in plain English and it's very helpful. And it gives a lot of help, and there are a lot of links there that patients can go to.
Okay, let's talk about gout arthritis. Okay. Gout is important. It used to be a rich man's disease, but what has changed here? Are we all rich, or we have changed our diet?
I think that was a misconception, because of course the rich people were of course more indulgent with the risk factors that come with gout, and that's probably why it was the rich man disease. And some people used to say the intellectual's disease as well.
Intellectual's disease,
yes.
Yeah.
But gout, of course, is a.
I had gout, so there should be intellectual disease then. Okay.
You think so? Yes. So gout is a condition which is a common inflammatory joint disease that is induced by acute severe pain. It particularly affects the big toe, but it can affect any toe, any joint.
So first time is big toe. Yeah.
And it is, as I said, it's acute severe. We call it a joint on fire. And according to literature and according to the patient's experience, it's the most unbearable pain that a male can have, apparently.
It is, yeah. It is definitely very painful.
Yes, so it is very unbearable. It is acute sudden joint swelling, and it is caused by uric acid deposition. Uric acid
deposition.
So let me explain a little bit about uric. Uric acid is a normal crystal or normal chemical, which is a breakdown product of a thing called purines. Purines are normal substances produced in the body and also found in food. So 3/4 of the purines in our body comes from the body itself, for the breakdown.
So 3/4 come from
body. And the other quarter comes from the diet. And we know.
So since we said diet, please go ahead with the diet.
Yeah, so diet, of course, there are protein, there's a seafood, fish, and things like that can cause increased purines. And of
Game
course,
meat as well as
red meat and as
Yeah.
of course the extent that we eat red meat now is not as much as we used to in the past, so it's not a big risk factor. But there are other risk factors. Increased intake of alcohol.
Alcohol. Yes. Is that any alcohol? Spirits, beer, cider?
Yes, any alcohol.
Any
Any alcohol in increased amounts can be quite detrimental because. So what happens is these are the risk factors. And I always tell my patients, uric acid is like if you had this concept of putting sugar into a glass of water.
Right.
You start putting sugar, it starts dissolving. It comes to a saturation point. At one point, it doesn't dissolve anymore.
Oh,
Because
right.
it has come to the saturation point.
Saturation
And
point.
therefore, after that, it just crystallizes.
Crystallizes.
And the crystals are the ones that are quite toxic. It can damage the lining and it can inflame the surroundings.
So in case, if you increase the water level, will it help?
How can you do that? You can't do that.
If you drink a lot of water, will it
no, I
wash
don't
out?
think being well hydrated is important.
So being well hydrated is
hydrated is very important. So again, dehydration is a risk factor.
Dehydration.
And then there are certain drugs like water diuretics or drugs that you can increases the urination can cause
And they dry you.
dry yourself and
Yeah.
then can induce. And again, there's another concept. Of course, we like to reduce the weight, but aggressive reduction of weight of this Atkins diet and all that is
especially these diets,
is detrimental.
because there is a lot of protein breakdown in your body.
And therefore there is a tendency for this to rise, the uric acid.
The kidney cannot handle.
Yes.
So this one rises. And as we saw, I think we kind of said the diagnosis, so this is clinical diagnosis. Isn't it?
Yes, it is a clinical diagnosis, but it's unfortunate that it is a very easily diagnosed and easily treatable disease.
So this one is treatable.
Treatable and almost curable, if you can pick it up early. The problem again, as I mentioned when you're better, you don't take the drugs, right? And I would like to emphasize here that this is a lifestyle disease. So when I say lifestyle diseases, we have to improve our lifestyle, which means you have to maintain a good body weight.
Good body weight.
A good diet.
Good.
Right? Good diet. And if you do get hypertension, diabetes, you need to control them well. Right. Because if you have diabetes, if you have high blood pressure, and if you are obese, if you have uric acid in your blood, it increases the risk of heart attacks. And we call this the metabolic syndrome.
Right.
Okay. So it's important that you treat the gout as well as the other common diseases.
Other common diseases are hypertension, diabetes,
and obesity.
And your weight.
Yeah,
obesity.
Very important.
So diet means what kind of diet?
So again, of course, a normal, well-balanced diet is what we recommend. There is no particular diet that we can say is proven. Of course, there are medications or there are diets which are low in purine, but it is an individual thing. Some people get triggers when they take Marmite, some people get triggers when they eat tomatoes, some people get triggers when they eat shellfish. So you have to find which is your trigger. Some people cannot eat cheese. Again, it's an individual thing, right? And we don't know why that is the case, but that might be because it's just changing the balance of the chemicals and the acidity in your blood.
In your urine, yeah. Exactly. So what kind of treatment you say for this?
So we have two ways of treating gout. We treat the acute attack. Okay, so I'll start off there. Acute attack, first and foremost, you treat it as soon as you get a niggle of pain. So you don't wait until it catches fire. If it catches fire, it takes it 3 weeks, whatever you do.
Wow.
So we tell our patients, with the slightest niggle of pain, you start treatment. And what is the treatment? Rest. Keeping ice pack.
Rest, ice pack?
Ice pack, and taking any form of pain tablets, particularly ibuprofen or naproxen.
Yeah.
And of course, if you have seen a rheumatologist, we will give a tablet called colchicine. Colchicine, which is just to treat the acute attack. And if you can't take colchicine for whatever reasons, then we can give steroids.
Yeah.
And if it becomes really bad, we can inject that particular joint with a steroid injection as well. So that is the acute attack. Okay. But the prevention is to bring the uric acid level below that saturation point that I was talking.
Right.
And that is long-term treatment. For that we have two drugs, allopurinol and febuxostat.
So what is the second one?
Febuxostat.
Febuxostat.
Yes.
Allopurinol and febuxostat. So first of all, okay, we said about that, but I think we forgot about the diagnosis. How do you diagnose? Are there any way you can take a blood sample and say that, oh, you
Yes,
got
so the
gout?
diagnosis, as I said, is the symptoms, and of course you can take a blood sample and see whether your uric acid levels are high. But one thing important to note is the uric acid can be normal, can be high or low.
So
during-
that's not specific
not
for the
specific.
disease.
So you might want to do a couple of uric acid levels to pick it up, because sometimes during an acute attack there is consumption of the uric acid and the blood levels go down.
Oh. So in case if you found it, your uric acid is hugely high, then at least you
Yes.
know that it's there.
And the diagnostic, the gold standard is to take fluid from the joint and look for crystals.
I'll look for crystals.
And if you see crystals, there is no doubt at all that this is induced by uric of gout.
But if you have the classic symptom, do you still have to fluid?
And you don't have
You
to.
don't need to.
No, we don't.
Probably it's
Yeah.
causing an infection
That's
or
right.
anything. All these things. Okay, let's talk a little bit of prevention. How we can prevent this gout happening again. We talked about the medications. What else can they do?
So again, if you look at the risk factors, is how we talk about prevention. So weight reduction, not a rapid weight reduction, a gradual weight reduction.
Yeah.
Avoiding severe dehydration.
Dehydration.
Trying to avoid the medication that can induce gout, so the diuretics. There are a few drugs, so you can always discuss it with your GP or with your kidney doctors if you have gout, because there are certain drugs that we would not like you to have, especially which are given for heart conditions.
Heart conditions.
And then of course general good lifestyle of good exercise and avoiding stress if you can.
Stress, yeah. Stress coming everywhere now is
Yes,
for
it
everything, hypertension, diabetes, everything related to stress. Okay, we can't drink alcohol, we said, about the meat and seafood. Now, okay, there's a lot of things going on in the internet. If you read, they talk about apple cider vinegar, then this cannabis oil, you eating cherries or cherry juice. Are there any evidence based, or are they okay? What do you think about them?
I think there is no strong evidence either.
There's no strong evidence.
No, there is no strong evidence for any of those at the moment. But as I said before, individual triggers is to be checked with yourself.
Yes.
You can follow what triggers the attacks.
But if you take them, it's not going to harm you. Isn't it?
I wouldn't recommend cannabis.
Cannabis, cannabis oil.
No, I wouldn't recommend it, because there is no. It might be a pain relieving medication or element there, but there's no
potential addiction. That's
Yes,
right,
yes,
isn't
that's
it?
right.
Yeah. Okay, Roshan, thank you very much. So we have left with about a minute. Do you want to pass a special message to our viewers?
So, gout, from gout perspective, I would say please seek attention, because as much as it is a common disease, it can cause quite destructive joint disease. It can cause bone holes, bone erosions and destruction. Likewise, rheumatoid arthritis in today's day and age is a disease that is well treatable. You can have a normal lifespan. So we have a lot of people who indulge in native treatment and all that.
Roshan, thank you very much for being with us in this show. It was we have covered somehow both diseases, rheumatoid arthritis and gout. So thank you all for being with us in this show. Sorry we couldn't take all your calls, but we're going to answer your calls after the program. So if you want any more questions, you can always write to us at healthtalk@intv.co.uk, or you can always watch our YouTube channel, Health Talk with Dr. Akram. We will post this video soon by next week, and you can always write on Facebook or Instagram, or we'll come back to you. So until we see you in the next program next week, look after yourself. Thank you very much.